So we are now recording. So everybody, welcome to our webinar tonight. My name is Eileen Michelli, and I work with the Marfan Foundation. And this is our webinar series called Prepare for Victory Virtual Medical Symposium Series. We created this program because we want to give you, no matter where you are in the world, the opportunity to hear the best information on Marfan syndrome and related conditions from our professional advisory board and other leading medical experts on these conditions. Our speaker tonight is Dr. Alan Braverman, who is an adult cardiologist. He's professor of medicine at Washington University School of Medicine and the director of the Marfan Syndrome Clinic at Barnes Jewish Hospital in St. Louis. Dr. Braverman is both a member of our professional advisory board and a member of our board of directors. And so this presentation, as you know, is taking care of your aorta. As I mentioned when we were getting ready tonight, in the Q&A box, you can put your questions, and then Dr. Braverman will first give his presentation, and then we'll get to the questions afterwards. And there will be time for that. And if for some reason we don't get to your questions, we will help you with that afterwards. So I'm going to now, here comes the fun part. I'm gonna stop sharing. Oops, and I should not have done that. So, so what I'm going to do is I am going to give the remote control to Dr. Braverman so that he can now share his slide.
Now, do I push the share button on this?
Yeah, you share. Yep, you press new share and then you pick your slides.
This will stop other screen sharing. Do I want to continue?
Yep, yep.
Okay.
Yep, so I'm waiting for you to control the screen. There you go. Now you can share and there's your slides. There you go.
Great.
All yours.
Well, welcome everybody. Thank you, Eileen, for the introduction and for the invitation to speak about a topic that I'm very interested in, and really is one of my passions, is helping everyone understand how to take the best care they can of the aorta, which we call the tube of life. So today, my tasks are as follows. I can move the slides. I'll discuss the aorta and give the Aorta 101, which is a brief anatomy and physiology lesson about the aorta. Then we'll talk about how to image the aorta, some of the pearls and pitfalls about tests that you'll have done to evaluate the aorta. We'll discuss what the latest is on medical therapy to protect the aorta, highlight some of the issues on exercise and pregnancy concerns in genetic aortic conditions, talk about how do we decide about the optimal timing for aortic aneurysm surgery, and then discuss aortic dissection. What is this condition? What symptoms are present? What's its treatment? And how to follow up. The aorta is the largest artery of the body. So it arises from the heart, this red tube, and that's the ascending aorta as it arises, and it carries all the blood to the vital organs of the body. It's about the size of a large garden hose as it exits the heart, and as it gets farther away from the heart, it becomes smaller because it doesn't carry as much blood. And it's divided into the sections in the chest as it ascends and descends, and then into the abdominal aorta and its branches. Another way to look at the aorta is like this. This is a typical view. Look at it like a candy cane, and you might, or a cane that you hold on to walk. So the heart is here below the aortic annulus. In Marfan and related disorders, the proximal aorta, the sinuses of Valsalva, where it bulges out here, is the largest part, and that's the part that's abnormal in most genetic aneurysm disorders like Marfan syndrome and Loeys-Dietz syndrome. Some other aortic disorders like familial aneurysm syndromes may involve the ascending aorta and spare the sinuses, but this is the part of the aorta, the ascending aorta, that's most involved in aneurysm disease, and it can be imaged very nicely by an echocardiogram or a CT scan. The part of the aorta where the great vessels to the head and neck arise is called the arch. That's the arch part. And then after the blood vessel to the left arm, called the subclavian artery, is the descending aorta. And at the level of the diaphragm, or when the aorta leaves the chest and enters the abdominal cavity, we call this the abdominal aorta. And it's divided above and below the kidney arteries, the suprarenal and infrarenal aorta. So that's the aorta. And the aorta is not just an inert structure. It's alive, and it has vital parts to it. It has 3 layers. One layer, the inner lining, so the blood goes through the center of this tube as the aorta, and it has endothelial cells. And then it has a muscular part called the media, and the media has elastic fibers, and that gives the aorta its strength, because you can imagine every time the heart beats, it propels blood through the aorta at a force, and it distends and relaxes with every heartbeat, and the aorta has to withstand that pulsatile flow over a lifetime. 80,000 times a day over somebody's life, blood's being injected into this aorta. It's an amazing tube of incredible versatility. And in connective tissue disorders like Marfan and others, it's the media of the aorta, these elastic fibers that make up the muscular part of the media, that become abnormal and lose their elasticity, and the aorta can then form an aneurysm or an enlarged aorta, a dilated segment that's subject to risk of aneurysm formation or dissection. It's that condition of the aorta, cystic medial degeneration, which is also called, in the old days, cystic medial necrosis, or currently we sometimes call it myxoid changes, is a descriptive feature of the aorta that you can see on pathology. So on the right side of the screen where it says elastin stain normal aorta, this is a stain for elastic tissue, and these normal wavy fibers that are lined up in perfect order here is the normal elastic fibers of the aortic media. And so again, like a sponge, every time the aorta distends, they contract and relax, and impart that they take up kind of a shock absorber for the force of the pulsatile flow of blood. On the left side of your screen is an elastic stain in someone with an aneurysm in Marfan syndrome. And you can see that these elastic fibers are now fragmented. So these black or blue fibers are broken or fragmented. And there's a lot of just cystic spaces and mucopolysaccharide accumulation in this tissue. This is called medial degeneration. And this leads to weakening of the aortic wall, which forms an aneurysm. And that's the underlying pathophysiology of Marfan syndrome. Now, the aorta size, again, depends on a person's size. So when we see somebody in the clinic for, is the aorta enlarged, or how does this fit for somebody? An aorta of somebody who's 5'6" is a certain size, just like your hands and feet would be. If somebody's 6'6", their hands and feet have to be bigger to meet that frame, and so does the aorta. So the size of the aorta is dependent upon one's age, one's sex, and one's body size. And this screen, this figure on the right, which has a gray rectangle, is kind of the roof. And as one gets bigger and one gets older, the aorta gets bigger and older up to a certain level. And in general, an aortic size in an adult over 4 centimeters would be the upper limits of normal size, whereas 3.7 in a female. So bigger, older men have larger aortas than smaller, younger women. So we know average sizes of the aorta, and we can use this knowledge to calculate a Z-score, which is just a way to think about an aortic dimension compared to normal. So a normal aortic size would have a Z-score anywhere from 0 to 2. Anything more than 2 would be 2 standard deviations above the average, or we'd consider it enlarged for that person's age and that person's size. The aorta does increase in size in all of us over our lifetime, but a very small amount, less than a millimeter per decade of life in men or women. So the aorta grows very, very slowly over a normal lifespan. And aortas that grow more rapidly, we think about underlying disorders that make them grow more rapidly. An aneurysm is an enlarged aortic segment. So it's pathologic, meaning it's abnormal, and it's larger than expected by at least 50%. So that's one criteria. Sometimes we'll say the aorta is enlarged, sometimes we'll say it's dilated, and sometimes we'll call it aneurysmal. They're all 3 adjectives really for the same description, just different ways of thinking about the aorta. And when we think about aneurysms or enlarged aortic segments, many people think about this type of aneurysm, a saccular aneurysm. So here's the abdominal aorta above the kidney arteries, and it's kind of bulged out on one side, like you might think of a bullfrog's throat bulging out there. That's a saccular aneurysm. That's the least common type that we see in connective tissue disorders, but it's the type we worry about most because there's more pressure on one side of the aorta. This is an abdominal aortic aneurysm called fusiform. This is the most common type. So in in a fusiform aneurysm, the aorta is symmetrically enlarged. So instead of this size, it's this size. So this is quite a bit larger in this aneurysm. And this is a pseudoaneurysm, which is where the artery is perforated and is contained by tissue surrounding the aorta. This is the most worrisome type. That's uncommon unless there's been trauma to the aorta or aortic surgery. Now, in Marfan and Loeys-Dietz and familial aneurysm syndrome, as I mentioned, this is an echocardiogram showing the aorta. This is the muscle part. This is the aortic valve. And the part on either side of this arrow is the aortic root at the sinuses of Valsalva and the ascending aorta. And this is the type that, this is the part that dilates in Marfan and connective tissue disorders. It kind of looks pear-shaped at the base, and this is the tip of the pear here. And we can measure the size of this very accurately by echocardiogram, or on the right panel by a CT scan. And again, this is a CT scan looking at the proximal aorta. This is the heart muscle down at the lower segment. Can, Eileen, are you on? If you can hear me, I wanted to see if,
yes,
I hope you can.
Yes, I hear you. Can
you see my arrow? Can you see
yes,
the arrow
I can.
when I'm? Okay,
yes.
Perfect. So this is the heart muscle, and this is the aortic root. Again, it looks pear-shaped. So this is a typical Marfan aorta. It has a pear-shaped appearance to it, and it's largest in the aortic root. And so we can measure this dimension or compare it to this dimension, and these are usually pretty interchangeable. Sometimes we don't see the aorta as well because it's shadowing or the pictures just aren't as clear, just like sometimes on a television screen or other things. They're just not as clear as this, so we have to use the best modality to see this. Now, a chest X-ray can show features on an aneurysm in the chest, but it's notoriously inaccurate. So this is a normal chest X-ray over here on my left, and the lungs are in black, and the aorta sits right here, and then it arises. And this is a knob, and then it comes down the back. So this is a normal chest X-ray. And you can see here, there's a descending thoracic aneurysm shown by these black arrows. So this bulge here is a big aneurysm there. So that's easy to see an abnormality there. But the problem is aortic root aneurysms in Marfan and others hide right behind the heart because it arises from this part of the heart. So you can have a very large aneurysm in a normal chest X-ray. This is a red aneurysm of the aortic root in a person, and you won't see it on a plain chest X-ray. So you have to image in other dimensions, in other methods like CT or MRI. So echocardiogram is the most common method, and as this cartoon on the right shows, we can make very accurate measurements of the aorta as it arises in multiple segments and use that to compare time and time again and try to be accurate about this. But as you can imagine, if we cut the angle off obliquely or at a tangential angle, or we take a slice at a smaller area of the aorta, it won't be as accurate. We want to get the largest part of the aorta each time and compare it side by side to see if the aorta has changed in diameter. I want to show you an example of one of the pitfalls we can see. This is a CT scan with contrast lighting up the ascending aorta and descending aorta in a person with a very large thoracic aneurysm, this large circle here. So on a CAT scan, we take slices like a loaf of bread, and this is a slice through the sternum, the breastbone, and the spine at the level of the ascending aorta. And at this size, we can make a measurement of the aorta, assuming that it lines up exactly perpendicular to the aorta, so we can make to the chest wall, so we can make a measurement this way and make a measurement this way and get a dimension of the aorta. But if the aorta is at a bit of an angle, this measurement will be inaccurate. And that's one of the most common reasons that we get larger aortas than normal, because the aorta is coming out at a bit of an angle. So when we take a slice through the aorta, it's an oblique angle, not a perfectly round angle, not a perfectly round aorta. So we know this and use techniques to make accurate measurements, as I'll show here. So this is a three-dimensional reconstruction of the thoracic aorta, and this is the largest dimension at the sinuses. This is in the ascending aorta, number 3. Number 5 would be at the arch, the proximal descending aorta, number 6, and the middle descending aorta, number 7. So very easy to measure here. And here's another picture of a cartoon of an aorta that's sort of tortuous and comes out at an angle. So when we do a CAT scan, measurements are done straight across like this. So you can see if I slice like this, it's not going to get a true dimension, and this is very common. So here's the aorta through the center line, and we do a double oblique. So we try to make accurate measurements. But if I make a straight front to back measurement there, you can see that's not a true dimension. That's going to make the aorta look like an oval shape or an egg shape, and that'll get an aneurysm size of 6 centimeters, which is false. If we do an accurate measurement in the true dimension, the aorta is only 4 centimeters. So we understand this, and it's very important to make sure that accurate measurements are performed. This is one of the most common reasons to overestimate aortic dimension, because the aorta is not measured correctly. So measuring the aorta is vital in importance in determining whether the aorta is enlarged. Now, how often should I have aortic imaging? And it really depends on the condition, the size of the aorta, and how rapidly it's growing. So for Marfan and Loeys-Dietz syndrome, we recommend once a year aortic imaging, as long as the aorta remains at a similar size. If the aortic size increases rapidly, such as 3 millimeters a year or more, then we certainly would recommend more frequent imaging. If the aortic size is approaching a diameter, like more than 4.5 centimeters in Marfan syndrome, where we're thinking about surgery at 5 centimeters, then perhaps every 6 months instead of once a year. Unless it's 4.5 year after year after year, then once a year is adequate. And again, the most common reason for an increase in the aortic size more than 2 or 3 millimeters is an error in the measurement. The standard error of measuring an aorta by an echocardiogram is 1 or 2 millimeters. So if it's different in size by 1 or 2 millimeters, it's likely just because it was measured differently this time versus last time, as opposed to a true increase in size. So it is very important, again, to have the same people look at your echocardiograms side by side and make the same measurements in the same institution, if at all possible, and have your provider look at those echocardiograms or CT scans to see if the aortic dimension has truly changed in size, which would be important to know, or was just a change in the way the aorta is measured. So once a year for an echocardiogram is typical. Unless the aorta gets to be a certain size, then every 6 months would be more appropriate. A CT or an MRI scan is recommended upon diagnosis in Marfan syndrome to make sure the aorta is not enlarged in other segments. In Loeys-Dietz syndrome, aortic imaging from head to pelvis, so head CT or MRI, chest, abdomen, pelvis would be recommended upon diagnosis. And then depending upon the dimensions and whether the aorta is enlarged or not, then it could be once a year or could be every other year to evaluate the aorta away from the heart. And again, if the aorta is not well visualized on an echocardiogram because of a pectus abnormality or lung disorder or something like that, then we do recommend an MRI, because no radiation is used, or a CT scan to evaluate the aortic size. After aortic surgery is performed, or certainly after aortic dissection, then at least annual aortic imaging is done after aortic surgery, and more frequent aortic imaging after an aortic dissection. What are the basic concepts in medical management? In other words, non-surgical therapy of aortic aneurysm disease. We'll talk about medications, learning about the condition, lifestyle modifications, exercise, and then guidelines for pregnancy. There are medications which are useful in Marfan syndrome and other related aortic aneurysm conditions. Some of these are based on randomized controlled trials, and some of these are really just based on our best judgment without evidence in people, but some evidence in laboratory animals. The first therapy that's typically used is a beta blocker, and beta blockers block the effect of adrenaline on our vascular system. So when things get us excited, like exercise or emotional stress, our heart rate goes up and blood pressure goes up, and that leads to more force on the aorta. Beta blockers block that effect, so the blood pressure doesn't rise as high and the heart rate doesn't go as fast during physical or emotional activities, and it lessens the stress and strain on the aorta over a lifetime. And there's been demonstrations of beneficial effects of beta blockers from the very earliest studies dating back well over 30 years ago now, with this study published almost 25 years ago. comparing aortic size in people with Marfan syndrome followed at Johns Hopkins. On the top bar are individual slopes of aortic growth, with a faster aortic growth over 10 years in people treated with control, meaning no medication, compared to treatment group, which was beta blocker. And a couple of these patients with the black arrows didn't take any medications. The aorta grew more rapidly, but on average, the aorta grew more slowly in beta blocker treated patients. So that's the background of beta blocker therapy in Marfan and related disorders. And it's a typically first drug used, and I'll talk about alternative agents which are as effective compared to beta blockers. So in our guidelines, beta blockers are recommended for Marfan syndrome to reduce the rate of aortic dilatation. And research from many investigators throughout the world, particularly the group at Johns Hopkins, have demonstrated that there's more to it than just blood pressure and heart rate control. That the fibrillin protein, which is abnormal in Marfan syndrome, affects growth factors, including TGF-beta. And in the mouse model of Marfan syndrome, the deficiency in fibrillin leads to excess TGF-beta signaling in Marfan tissues. And that has been recognized to be an effective marker to treat in different conditions. So this is a cartoon of what's going on this microcellular level. So in a normal host, so someone who has normal microfibrils or normal fibrillin, through a set of binding proteins, TGF-beta, which is the activator for cellular events, is held hostage or is kept at bay. In Marfan syndrome, there's abnormal binding proteins to the abnormal elastic tissue or the microfibrils, which allow this TGF-beta to stimulate receptors on the cell surface and lead to downstream signaling and nuclear events, which lead to features of Marfan syndrome, including lung findings, aneurysms, muscle problems, and mitral valve prolapse. And what's been recognized through the animal model is that blocking TGF-beta signaling can lead to normalization or normal features in the Marfan mouse, including absence of aortic aneurysms, mitral valve prolapse, and emphysema in the lungs. So that led to trials of agents such as medications such as losartan, which blocks TGF-beta signaling in Marfan patients, and led to multiple trials, including the largest trial, which I'll mention in a minute. So in a Marfan mouse, losartan, by blocking TGF-beta, improved the aorta. So this wild type means a normal mouse, and between these arrowheads is a normal aortic dimension. And you can see a Marfan mouse treated with a placebo, which is a sugar pill, still formed aortic aneurysm in column C here, graph C. Graph B was a Marfan mouse treated with a beta blocker. So the aortic aneurysm still formed compared to normal, but it was smaller than placebo. And losartan, which blocked TGF-beta, normalized the aorta exactly the same as a normal mouse. Looking at the tissue, these are these wavy elastic fibers in a normal mouse, and this is a Marfan mouse treated with losartan, and this showed the absence of cystic medial degeneration. Remember, we talked about that earlier, showing this fragmentation of these elastic fibers in a Marfan mouse treated with a placebo. Beta blocker treated Marfan mice had improvement of the elastic tissues, but still had fragmentation and enlargement of the aortic wall. So this gave great hope that losartan could do the same in people. And unfortunately, fortunately, it is helpful, but it has not been yet proven in the largest trials to be better than beta blocker in single treatment, beta blocker versus losartan in Marfan syndrome. So currently, with Marfan syndrome, our recommendations are to treat with either a beta blocker or an angiotensin receptor blocker, such as losartan. And important in this treatment, and this has been borne out in the trials, is to use the highest dose tolerated, not just being on a beta blocker or an ARB drug like losartan, but take the highest dose that one can to have the best benefit of either agent. And many of us choose to use both agents together in treatment, hoping to get a even more robust effect. And there are other trials ongoing, some that have been recently published, in abstract form, and there'll be a meta-analysis of all the trials of losartan or other ARB drugs versus beta blockers that'll be upcoming to compare what the best treatment will be. And this gives us a lot of hope for the future on other ways to block TGF-beta. Some argue that more potent or more effective ARB drugs, stronger than losartan, may be a better bet in Marfan syndrome. Taking care of the aorta, knowledge is power. So know about your condition. Everybody with Marfan or a related disorder should know they have the condition, should know about their aorta and its size, and know that they require long-term follow-up and serial imaging, and ask for these studies during your routine follow-ups if it's not being proposed, to make sure that you're having appropriate follow-up. And then know the symptoms which could represent an aortic dissection. So have an action plan. Should a symptom develop, what would a symptom feel like? How would I know what to do? Who should I call? Where should I go? What should I ask for? So these are actionable items with a plan that'd be very helpful to have for yourself and to tell your family members should you not be able to communicate all the features because of symptoms you're having at the present. It's very important to know about your physical activity and talk to your doctor or practitioner about what your work is and what sort of exercise you like to do or want to do if you have Marfan or related disorder. People who have thoracic aneurysm disease and a genetic syndrome are restricted from participation in most competitive athletics, whereas recreational sports and physical activity can be done at low risk for almost all individuals as long as certain caveats are understood, which we'll talk about in a minute. When you think about exercise and physical activity, of course, they're different. Whether you're doing leisurely walking, which would be a dynamic or isotonic exercise where muscles contract and relax along their length, and this does not lead to much blood pressure rise during leisurely recreational walking, as opposed to doing a static or isometric exercise, which would be straining of muscles with intense weightlifting or straining or pushing or pulling against your body weight. Muscles contract there without movement, and that leads to a marked increase in blood pressure, and that puts more force on the aorta. So in underlying connective tissue disorders, we want to favor a dynamic or static exercise and try to avoid intense isometric exercise with any sort of frequency. And there's a marked difference between doing competitive athletics, which involves systematic training and trying to do your very best for yourself or your team, pushing yourself to your highest natural physical limits, versus a recreational athletics, which is fun, non-competitive, is important for lifestyle, social issues, and good health, but doesn't involve the same stress and strain on the aorta, the eyes, the ligaments, etc., which are important in connective tissue disorders. This is an example of a bodybuilder and a weightlifter who suffered an aortic dissection. He did not have Marfan syndrome, but this is the sort of person I don't not want to see in my clinic who has one of these, who has a genetic condition. This is something that we would say we'd recommend against. So while low levels of exercise, weightlifting and training is safe in almost all individuals when you avoid straining or stressing muscles and by doing low amounts of weights, but intense weight training can lead to marked increases in blood pressures, and there are reports of aortic dissection related to intense isometric exercise. So we think about exercise and physical activity as to how many metabolic equivalents are being required. And this is a nice table which helps think about these sort of things. And in general, sitting and resting would be a metabolic equivalent of about 1. And then walking slowly or fishing, playing musical instruments, housework at light levels would be low. And brisk walking or recreational tennis, leisurely swimming, yoga, water aerobics, playing golf, these would be more moderate. And then more than that involves a little bit more stress to the aorta. So we really try to avoid intense hiking, jogging at this level, shoveling of snow, in basketball, soccer. Singles tennis, unless done very recreationally at a low level, is more rigorous. So we really want to stay in the yellow or green with our physical activity and sports in most circumstances. It's important to recognize that being on a medication for the aorta, such as a beta blocker, which slows the heart rate and lessens the force of contraction, does not protect one against aortic events, such as aortic enlargement or aortic dissection. So just being on a beta blocker does not allow somebody with Marfan or Loeys-Dietz or familial aneurysm syndrome to perform competitive athletics or do intense weight training. Losartan doesn't have an effect on heart rate, but does lower blood pressure, but still doesn't protect one against physical activity in sports at high levels. And if you're on a blood thinner because of a heart rhythm disturbance or a mechanical valves placed in the heart, remember that certain physical activities, which could involve collision or falling or traumatic injury, could lead to excess bleeding because of the blood thinner. So we want to avoid contact sports if you're on a blood thinner, and contact in competitive sports if you have an underlying connective tissue disorder like Marfan or related disorder. Pregnancy is a risk factor for aortic dissection in women who have Marfan and other genetic aortic conditions. Most of the information we have about that risk comes from women with Marfan syndrome because of the number of years it's been able to be studied and the number of women followed in this condition. So each pregnancy is considered at increased risk, even when the aorta is normal dimension or mildly enlarged. And the risk of an aortic dissection, if the aorta is less than 4 centimeters or 40 millimeters, is calculated at about or estimated at about 1%. So it's not zero, but it's low. But compared to somebody without Marfan or a related disorder, it's much higher. When the aorta is enlarged more than 40 millimeters, we think it's much higher risk, and that risk increases as the aorta gets larger. So we want to image the aorta and have conversations about pregnancy risk and family planning well before one becomes pregnant in Marfan and related disorders. If pregnancy commences, then echocardiograms during pregnancy and follow-up evaluation with a maternal fetal medicine specialist, a cardiologist, and other medical geneticists during pregnancy with imaging at least once every trimester is recommended. And then precautions about avoiding the Valsalva maneuver or bearing down during labor and delivery is very important. So epidural anesthesia and assisted deliveries are important. And in some women, a cesarean section is important when the aorta is significantly dilated. So it requires a multidisciplinary approach to management. We've just completed a study, which is in press now, about the risk of pregnancy in women with Marfan syndrome who've had aortic root replacement, and summarized the data on 20 women from our institution, Johns Hopkins, and through a Marfan Foundation supported a research project. And in our 20 women with 24 pregnancies, there were actually no aortic dissections after root replacements. And in the literature, though, it's a much higher risk. So we think in combining all the data that's available, this probably still is up to about a 10% risk of aortic dissection in Marfan women who have pregnancy after successful root replacement. And so precautions are necessary and information must be shared. When should one have aortic surgery? In general, in Marfan and related disorders, once the aorta achieves 5 centimeters, it's recommended to have prophylactic surgery. And this data comes from large experience, and this is one such data set from Guillaume Jondot from Paris, looking at events in 732 patients with Marfan syndrome. So up here says aortic event without surgery, and you can see when the aorta is under 5 centimeters or 49 millimeters here, there were 2 events out of 157 patients and 675 years of follow-up. So the annual risk of an aortic dissection, if the aorta is under 5 centimeters, is 0.3. So it's not 0, but it's close to 0, 0.3. And once the aorta becomes more than 5 centimeters, the risk is about 1%, between 5 and 5.4, and more than 5.5, it's much greater, 8%. So we usually choose 5 centimeters with caveats. And those caveats are as follows. So it's not strictly a line in the sand, and we often choose an aortic dimension a little less than 5 centimeters, and we start thinking about it when it's 4.5 centimeters or greater. If there's a family history of an aortic dissection, especially if the aortic dissection was known to occur at a small aortic size, if the aorta is diffusely enlarged as opposed to just in the sinuses, if there's been a dissection present in the distal aorta, that's a risk factor for proximal dissections. If the aorta grows very rapidly, if there's a very large aorta, 4.9, 4.8, in someone who's much smaller, especially a smaller woman, if the mitral valve requires surgery and the aorta is dilated at a certain size, we say, why don't we fix the aorta at the same time since one's there anyway? If the aortic valve is leaking significantly and that needs to be fixed, we'll fix the aorta. And in many circumstances, when the aorta is under 5 centimeters, it's really a patient desire. There's a good time socially or professionally or because of school or because of the worry that something could happen when the aorta is getting close to 5 centimeters. So in general, 5 centimeters is the target size in Marfan syndrome. Somewhat smaller can be done in these conditions, or if it's really important for the person to go forward now, especially when a valve-sparing root replacement is recommended, because it's easier to do the surgery before the aortic valve starts to leak, which it can once the aorta gets to be stretched too much. In Loeys-Dietz syndrome, we recommend the aorta be operated between 4 and 4.5 centimeters, depending on the specific mutation, the family history, the gender, craniofacial features, or other phenotypic features. So somewhere in this range, it's recommended for surgery. In familial thoracic aortic aneurysm disorders, there's not a lot of information. We're learning more about this through large registries that are ongoing, such as the Montalcino Aortic Consortium and others around the world, somewhere between 4.5 and 5 centimeters, depending upon the mutation, the family history, the size, the rate of the growth of the aorta, sex of the individual, and others. So there's much less information to be very granular in Loeys-Dietz and familial aneurysm syndrome, so there's a little nuance in this depending upon a lot of factors. In younger patients with severe craniofacial features and marked phenotypic features of Loeys-Dietz syndrome, 4 centimeters or greater would be recommended for surgery. If it's picked up later in life, and if someone has a TGF-beta mutation, 4.5 centimeters would be very appropriate. So there's a lot of shared decision making that goes on in these sort of decisions. The surgery can be a composite valve and root replacement or a valve-sparing root replacement. Finally, what is an aortic dissection? What does it feel like? This is an intraoperative example of an aortic dissection provided by Joe Bavaria from Pennsylvania. The heart's pumping here beneath this fat, and this is an aortic aneurysm that one can see through. You can see the flap of the aortic dissection through this very thin-walled aorta. You can see blood circulating through this very thin-walled aorta. So this is a surgical emergency. An aortic dissection is a tear in the aortic wall. So there's 2 channels then. This is the intimal flap. This is called the true channel or true lumen, and this becomes the false channel, which can be recognized on imaging studies. And we divide these into the type A, which involves the ascending aorta and can extend throughout the aorta, or a type B, which involves the descending aorta. Anything involving the ascending aorta is a surgical emergency, and a type B dissection can be often treated medically initially unless a complication occurs. Most patients with Marfan and related disorders have type 1 dissection, so it's just above the aortic valve and requires surgery. Important to recognize is this part of the aorta is typically operated while the rest of the aorta is typically observed. So patients after a dissection usually leave the hospital with a persistent dissection down the descending aorta. The symptom of a dissection is usually abrupt, severe chest pain or back pain, something that's never had before. Sharp and severe are the most typical adjectives. Some people describe it as ripping or tearing. It can be migratory or radiating, starting in the chest, going to the back or to the head or neck or face or into the abdomen or leg. It often makes one feel very restless with a sense of doom, and one can't become comfortable. but it may not be as severe as you thought, and it certainly may not be as severe as the doctor thinks it should be, and so it may not be recognized. So you have to advocate for this and be aware that this could be an aortic dissection, and to have imaging done if there's a symptom or a sign that could be consistent with this disorder. The surgery of an aortic dissection involves replacing the aorta with a graft, but not with an endograft. So this is important to recognize. Endovascular therapy, which is much safer and easier than open surgery, has much more complications in Marfan and related disorders because of these prongs on the end of the endograft can traumatize or damage the aorta. There can be leaking around the aorta and late aneurysm formation. So there's many more late complications. And at present, the professional board of the Marfan the Marfan Foundation does not recommend endovascular therapy except in life-threatening complications which cannot be treated surgically at a low enough risk for an individual. So this is a life-saving measure for patients that can't make it to surgery or for which surgery is felt to be much riskier, and that's like in an acute situation. So this requires a lot of thought by an expert if an endovascular repair is going to be done. It's not recommended for elective procedures in Marfan and related disorders, except under very special circumstances. And then finally, it's important to recognize that after a dissection, this is a type B dissection, the aorta will grow over time. That's the natural history, and it has to be imaged. Medications have to be taken, lifestyle modification, and repetitive imaging. And when the aorta gets to be a certain size, surgery is recommended. After an aortic dissection, we want people to be active. The aorta is much stronger than you think. So early on, we recommend caution, and then we like to return to more normal activities with caveats. Avoid excess exercise and weightlifting, but in patients that do return to more physical activity after an aortic dissection, they have lower blood pressure and less depression. So take care of your aorta by doing the following. Get a routine evaluation by imaging. Know and remember your aortic size and have that followed. Take medications to lessen the stress and strain on the aorta or block signaling pathways. Remember safe levels of exercise and physical activity. There are precautions to take with a pregnancy. Have preventive aortic surgery when a threshold aortic size is met. Recognize the symptoms of aortic dissection and provide and have long-term follow-up. So thank you for the opportunity to speak with you today. And remember, protect your aorta. Protect the tube of life. Thank you very much.
Wow, thank you. That was really excellent. Thank you so much. I'm going to get my slides back here. And I know there's a lot of questions. I just want to take 2 seconds here and just tell people that now you know all the things you need to keep track of with your aorta, you know, the medications, your imaging, plus whatever else you're dealing with, whether you have Marfan or Loeys Dietz or another condition. I want to put a plug in here for Backpack Health, which is a new app that the Marfan Foundation is involved with. And through our partnership with Backpack Health, you guys can have access to the Pro app, upgraded app for free. You can put all your health information in one place. It's a way to securely manage, organize, and share important details about your health. And you can upload files, images, reports. This is all on our website, so I'm not going to go through all the details here. Also, by joining the registry that we have through Backpack Health, you can help advance research. So some of these questions about medications and surgery and which medications and when to have surgery, you'll be able to advance that research by sharing your information. Obviously, it's, you know, de-identified, it's aggregated, which means it's mixed with everybody else's, so it's not traced back to you. So that's another important point with that. And you can go to our website and you can join the registry, and it will really help you manage all that information that you're keeping track of with your condition and for everybody in your family. So now we're going to go to the quick Q&A box. I see a bunch of questions there already. So let's see. So here's one question right off the bat. If somebody does not have the aortic problem, does that mean the patient does not have Marfan?
The greatest majority of people, so that's a good question. So the question is if the aorta is okay, is it that they do not have Marfan syndrome? So the diagnosis of Marfan syndrome typically involves aortic enlargement, but it doesn't have to. You can have ectopia lentis and an FBN1 gene mutation and skeletal features of Marfan syndrome, where the FBN1 gene mutation is known to lead to Marfan syndrome in your family or another family. So it could be that the aorta just hasn't enlarged yet, and then follow-up would be recommended. But most patients with Marfan syndrome will have aortic enlargement on diagnosis, and the greatest majority of people with Marfan syndrome will have aortic enlargement during their lifetime.
Thank you for that. There's somebody who has 3 concerns for his doctor: aortic dissection, abdominal aneurysm, and arterial dissection. He said all less than action level. I'm not sure what that means. The question is, if the aorta is repaired, won't that cause the pressure to rise and quote unquote blow the others out? Is that too specific to answer here, you think, or is that something that you can?
That's an important question as well. So the question would be is, if you have your aorta repaired, like there's a dissection proximally or an aneurysm fixed, does that lead to abnormal forces in the aorta downstream from that, or does it affect that in any way? There's a lot of research going on to try to answer exactly that question. We do know that patients with Marfan syndrome and related disorders that have elective surgery on the aortic root for an aneurysm with a graft put in, a Dacron graft put in, that there is about a 1.5% per year risk of having aortic dissection distally. And that's a higher risk than there was before surgery, as far as we know. And what we don't understand is it because of the surgery itself, with putting a relatively, inelastic tube in where the aorta had been an elastic tube? Does that change forces downstream? Or is a person who's had aortic surgery because of an aneurysm just at higher risk? And there's a lot of experts who feel that, that having a graft put in may change the risk of aortic dissection downstream, which makes me hope that there will be engineering breakthroughs in the future to create graft material that is a shock absorber better than we have now. So it's an unanswered question. It doesn't increase blood pressure, though. It doesn't change the blood pressure downstream. It's possible it could change the way waves are reflected in the vascular tree, though.
Wow, thank you for that. Great question, and I'm glad you're able to answer that. I knew this was going to come up, physical activity. What do you tell somebody who is restricted? They can't play the sports that they really want to play. They're taking their medication, they're taking their losartan or their beta blocker, and they really want to play sports even though they know about the risk. People get free choice, but how do you counsel them to do what's in their best interest to protect themselves?
Well, what I really try to do is just try to understand how the person I'm talking with feels, and really what how they're willing to live their life. And as you said, it's really I can make recommendations, but I can't choose choices for other individuals. Yeah, and this is probably the most difficult part of caring for people with Marfan and related disorders. Thankfully, aortic dissection and complications of the aorta are rare in athletes, and that's probably because most people with Marfan syndrome are recognized early. There are people who've made it to the highest levels of competition and were never recognized, and we don't really know what would have happened to them if they would have been allowed to continue, because once they're recognized, they're not. So we don't really know is the truth. There's very little data to guide us objectively. So a lot of this is based on our best judgment. And so what I try to tell people is to try to live the safest life you can. You have a lot of years ahead, and but I wouldn't be able to give permission or blessing to do intense competitive athletics in the highest levels when one has a connective tissue disorder, because there remains a risk of aortic catastrophe which could strike even if the aorta wasn't markedly dilated.
And there's also issues with the eyes and the bones and joints. And what I would recommend is for people to take a look at this new resource that we have on our physical activity guidelines. They were updated. We the guidelines weren't changed, but Dr. Braverman and the other doctors we work with, they really went to great lengths to explain what they worry about. So it's not just saying what they recommend, but why, and so that everybody can make their best informed decision. I think that's really important to know, like, what you worry about, and so that they can decide, well, I'm going to worry about that too, or not. How about fluoroquinolines? Somebody asked about fluoroquinolines and the aorta. I know that's been in the news lately.
There have been at least 2, if not 3, large epidemiological sort of pharmacologic database surveys which have linked aortic aneurysm in one, and I believe the combination of aortic aneurysm and dissection in another, with an increased risk of those events in someone who's taken a fluoroquinolone within the year before, and some of them are within so many weeks, and some of them go up to a year. Now this risk is let's say it's a 2-fold risk to a 4-fold risk, something like that. Let's say it's a 2-fold risk or something, or it's an increased risk. The absolute risk is still very, very small in these populations, but the relative risk is higher. And so these aren't randomized, they're not controlled, they can't control for every other aspect like other risk factors, because we don't know all the other risk factors in the individuals. So I think right now I'm intrigued by this possibility, because fluoroquinolones, the medicines like levofloxacin and ciprofloxacin, are associated with tendon rupture. So Achilles tendon rupture, which is a collagen event, can occur in individuals who take those medications. So there is something about it, and the theory is that it impacts matrix metalloproteinases, which are enzymes which break down elastin, and it affects those. And so there is a theoretical background. And now the question is it a clinical background, and what do we do? So these agents are, of course, very helpful in certain infections. So if someone has an infection that requires an antibiotic, and this antibiotic is the #1 choice, then you have to think about, what are my alternatives? The FDA has not put any sort of warning on this, so we don't have anything like that at present. The Marfan Foundation Professional Board, I think, reviewed this when the FDA said, well, at present, we don't have any other information to make a black box warning or anything like that. So I think I'm curious about this. I think we are going to learn much more about it, but right now I think it's a hypothesis generating issue as opposed to something that's well established.
And I think that review by our professional advisory board is actually noted in the Connective Issues magazine that just came out. So that's on our website if people want to check that out. So do people with Marfan syndrome have a lower recommended maximum heart rate than somebody who does not have Marfan?
So in general, when the heart rate will be blunted if one's on a beta blocker. So that'll be slower than somebody who's not on a beta blocker. But in general, what I like to try to think about is when you do physical activity, do it at a pace where you can still carry on a conversation, or it's a light perceived exercise level. So on a scale of 0 to 10, you might be exercising at a 5 to 6 as opposed to an 8, 9, or a 10 where you're panting. And because generally when you're doing those sort of activities that are higher on that scale, your heart rate is faster. If you have a method to check your heart rate during physical activity, we might guide someone to try to keep your heart rate. Again, it just depends on the condition, what the aortic condition is, if there's been dissection or not, how big is the aorta, etc. But in general, keeping the heart rate during physical activity under 100 to 110 beats per minute is very safe for the vast majority of individuals. In some people, that's not fast enough because it starts out fast and they're intolerant of beta blockers. So really, it's a level of what's your perceived level of stress and strain during the activity.
Yeah, sometimes it's hard to put a number, but yeah, it's better to think about it that way. What is your take on personalized external aortic root support, or pairs?
I think the pairs is still heart surgery done, so it still requires opening the chest. This is kind of like a sleeve that's put around the aorta. It's currently, I think, only available in England. I'm not sure if it's available throughout Europe or not. It's not available in the United States, so we don't have it available through our FDA to perform that procedure here. But it's been done in I'm not sure what the numbers are yet, maybe between 50 and 100 individuals, and they've had very good success. I think there was one death related to that, where the aorta is sort of a personalized graft that fits the individual's aorta, is sewn or is placed around the aorta all the way from the coronary arteries up to the ascending aorta, and kind of encases the aorta in this mesh. And so far, in the individuals who've had that done, there has not been an aortic dissection or a requirement for a valve replacement. And so I think, 10 or 15 years ago, when we were learning about this, there was a lot of skepticism. I think it's being done in more individuals now in very specialized center. I'm interested in it because it is another way of dealing with this process. I think, again, time will tell as more people have the procedure, as it becomes more mainstream, as opposed to just being performed in one center in one country. So I'm very interested in this.
All right, we're going to do one more question, and then we'll kind of do a little wrap up. So does severe scoliosis or pectus excavatum affect the aorta?
No. So the having a thoracic deformity doesn't typically affect the aorta. The aorta follows the spine, so it becomes very tortuous. If there's a marked scoliosis, the aorta typically follows that same pathway, so it does have curvature. If somebody has a severe pectus excavatum, it can, infrequently, but it can impair lung function. It uncommonly affects heart function. Usually the heart is pushed to the side, but it can impair lung function and lead to symptoms of breathlessness or effort intolerance. And that's one of the indications to have a surgical approach to a pectus deformity. And sometimes that's done before having aortic surgery to make it easier for the surgeon to get to the aorta. Some surgeons will do it combined, but often it's done beforehand in a staged procedure, is to do the thoracic surgery first with the pectus.
Great. All right. Well, thank you. Thank you for taking all those questions. I want to thank everybody for participating tonight. We're going to take the questions that were not yet answered, and we will get back to you. Jan is the nurse in our help center, and she is going to, let's see, what are we going here? There's Jan. So we're going to share the questions with Jan, and the ones that, and she will work with Dr. Braverman and our other cardiologists on our professional advisory board to get you the answers that you need. Also, you can always contact her directly or ask the question page at our website. But we do have the questions that you've all typed in, and we are going to follow up with you on all of those. You want to get your questions answered. So our next webinar as part of this series is going to feature Dr. Hal Dietz, who's going to talk about Loeys-Dietz syndrome, which is one of the conditions related to Marfan syndrome. Has a lot of these aortic features, as Dr. Braverman explained tonight. And that's Thursday, November 8th at 6 o'clock. Again, you could go to our website, marfan.org, Patients and Families, Virtual Medical Symposium Series here on the left. Those are for our medical topic webinars. Also right below that, our empowerment series. Those are more quality of life issues that we address. And we'll be doing something on grief and grieving in November. So check that out, and you can click on there and then register. So thank you all again for participating tonight. There's a great turnout, and please let us know what else you'd like us to cover in these webinars. And Dr. Braverman, thank you so much for your time tonight. We really appreciate it. Thank you all.
It was my pleasure. My pleasure. Thank you.
Okay.
And I wish I would have had more time to answer your questions, which are very important to me to do that. So I'll do my best to try to answer the questions that you've written in and help with the support staff of the foundation.
Great. Thank you so much. We appreciate it. Everybody have a good night. Take care.